So good morning. My name is Erin Moran, and I am the Clinic Partnership Manager here at the MAVEN Project. Thank you all for joining us today for Shared Decision Making Prostate Cancer with Dr. Stephen Lieberman. You can go ahead, Dr. Lieberman.
Okay, thanks everybody for showing up for this talk. It's something that I requested to do because I've become kind of passionate about it. This is a disclosure and I have nothing to disclose. Aaron's talked to you about the accreditation. This is a little bit about me. This is not that important, so I'm going to get on to the talk. So I have been involved in PSA for 38 years. I know that it's 38 years because I started doing it in 1985 when my first daughter was born. And she's now 38. And I've been with PSA for 38 years, and I have both a personal response to PSA and what's been going on with PSA. And I'm very interested in the evolution of PSA over the 38 years, and that would be a whole nother talk, but hopefully you'll get an idea of how PSA has evolved over 38 years. And we're at a place now where there's still a controversy about PSA and using PSA for screening for prostate cancer. And there's a big gap between what urologists think is the right thing to do and what primary care people think is the right thing to do. And the primary care people, who you are and who I'm talking to right now, are informed by the U.S. Preventive Task Force and their recommendation, and by their societies like the Family Practice Society and those kinds of people who think quite differently about PSA than urologist does. And so hopefully you'll get an idea of why this is important to me and why it should be important to you. So in 2018, the U.S. Preventive Task Force updated their recommendation to not screen for prostate cancer using PSA from level D to level C. The AUA came out with a guideline for early detection of prostate cancer in May of last year, and I was privileged to be a physician reviewer of that guideline before they released it. It was a task that took me a couple of days, and it was a privilege actually to be part of that. So the U.S. Preventive Task Force originally came out with their recommendation in 2012 as a level D recommendation, which said that PSA was not worth using as a screening detection method because it didn't, they claimed that there was no difference in the mortality between a cohort of control group versus a group that was so-called screened with PSA. But between 2012 and 2018, the incidence of metastatic and advanced stage 4 prostate cancer went from 10% to over 20%. And we learned that 85% of those patients presenting with metastatic prostate cancer, and this is still true today, present with de novo disease. What does that mean? That means that 85% of patients that walk in off the street or come into your office with advanced metastatic prostate cancer and elevated PSAs have never had a PSA before, have never had a rectal exam, and have never had treatment for prostate cancer. 15% of those patients with prostate cancer have had PSAs and have had treatment as a result of the PSA. And I would venture to guess, although I'm not sure, that those patients also had advanced disease at the time of presentation. So I want you to take away a couple of caveats from this talk. One thing is that there's no such thing as a normal PSA. I know that when some of you are still getting reports that say that PSA less than 4 is normal, PSA greater than 4 is not normal, I want you to think of PSA in a different way. I want you to think that there's no such thing as a normal PSA because PSA is associated with a risk of prostate cancer and everybody's risk is different based on that PSA. PSA, as you probably know, varies with age. So as I'll show you in a little while, a PSA of 2 in a 50-year-old is absolutely not normal, whereas a PSA of 2 in somebody my age in their 70s is normal or associated with, let's think of it in terms of low risk. So a PSA of 2 in a 50-year-old is associated with a much higher risk of having clinically invasive or clinically significant prostate cancer than a 70-year-old. So I'm going to simplify the way that urologists, this is a very simplification of the way urologists look at prostate cancer. And the way you guys look at prostate cancer too, there's really no difference. Prostate cancer is prostate cancer. So there's indolent or low risk prostate cancer. That's the kind of cancer that people die with rather than from. It's a kind of cancer that's never going to grow to cause local problems, never going to metastasize. Most people don't even know they have it. And I would say that that's a majority of prostate cancers across all age groups. So, and then there's the opposite, which is aggressive high-risk prostate cancer. That's a kind of cancer that is high grade. When you look at it microscopically, it's the kind of cancer that's likely to grow both locally and metastasize. And then there's an intermediate risk of prostate cancer. Now, this is a simplification. It's more complicated than this, but think of it as 3 groups of prostate cancer: indolent, clinically insignificant prostate cancer, aggressive, clinically significant high-rate cancer, and then ones that we're really not sure of. The goals of screening or early detection should be early diagnosis of aggressive and intermediate risk, figuring out which of the intermediate risks are actually low risk and which are actually high risk, and then not diagnosing and not screening those patients who are likely to have low risk or indolent prostate cancer, with the knowledge that patients who are diagnosed with low risk prostate cancer or intermediate risk prostate cancer have a 1/3, 30% of those are going to progress. Okay. So with that in mind, let's talk about shared decision making and the kind of conversation that you and I are both expected to have with patients around whether or not to do a PSA. So shared decision making is something that I've thought a lot about over my career and since I've retired. It's a key component of patient-centered healthcare. It's a process in which you, the clinician, and patients work together to make decisions and to do tests, and then develop treatment plans and care plans based on clinical evidence that balances the risks and expected outcomes with patient preferences and values. So why is this important? Well, in 2023, there were 288,000 new cases of prostate cancer in the United States. There were 34,000 deaths from prostate cancer. The proportion of advanced and metastatic prostate cancer at the time of diagnosis has increased, depending on what data you look at, from either 4% to 8% or 10% to 22%. The 10% and 22% values, I'm lumping in locally advanced, not necessarily metastatic prostate cancer, or metastatic prostate cancer based on a PSA that's elevated, wherein all the imaging studies are negative for metastatic prostate cancer. So we know that they have advanced disease. It can either be locally advanced or metastatic that we haven't yet diagnosed. So the healthcare costs, and the increase in the metastatic and advanced prostate cancer is definitely due to the U.S. Preventive Task Force level D and then level C recommendations, because the same sort of increase in metastatic disease has not been seen in other countries. So the healthcare costs attributed to metastatic prostate cancer are $5.2 to $8.2 billion per year, which amounts to $34,000 per patient. And again, to go over some of this financial data, the cost of Lupron, which is a way of producing medical castration, was $232 million in 2020. Sipuleucel T, which is an immunologic agent used for treatment of metastatic prostate cancer, 113 million. Proliga and Xtiva, which are anti-androgens, 73 million. Firmagon, another anti-androgen, 15 million. And the most common anti-androgens now used are two drugs called abiraterone and enzalutamide. And they are covered some by Medicare Part D. And it costs the patient, even with Medicare Part D, the average cost is $1,000 a month out of pocket. And that's not even talking about what effect these drugs have on a patient's health, both mental health and physical health, because they're androgen depleted. They have no testosterone, and so they're depressed, they're weak. A lot of other thromboembolic phenomena occur, the effect on bone health. So there's a lot of bad things that happen when people are on anti-androgens. So more about cost. In 2021, there were 75,000 men who were on abiraterone or enzalutamide. The costs in 2021 were actually 3 times higher than 2020. This slide needs to be fixed. Medicare spent $4 billion with a B on anti-androgens in 2021. And as I said, the out-of-pocket cost for Medicare Part D patients is $10,000 a month. And it was improving due to the Inflation Reduction Act, but not that much of an improvement. And the drug companies expect the costs and profits of anti-androgens to continue to rise, and they're heavily invested in research in these drugs. And every time I hear about a new one of these drugs being used, I sort of want to scream and think this could all be prevented. So, shared decision-making in urology is not just limited to prostate cancer, but both the early diagnosis of prostate cancer and the treatment of prostate cancer, because every time we make the diagnosis of prostate cancer, we go through a very detailed and involved discussion about the options for patients, including no treatment at all for what we think is a low-risk prostate cancer. But when we have a patient with stones, we talk to them about a shared decision-making conversation can take place about prevention of further stone disease. We can talk to them about treatment of their stone disease, and there are many options for various types of kidney stones. Other urologic malignancies, kidney, bladder, testis, they all involve some sort of shared decision-making around both diagnosis and treatment. Even something as simple as a circumcision in a child or an adult can involve a shared decision-making conversation. Patients with recurrent UTIs or options for treatment, drug options, various drug suppressive antibiotic therapy versus other methods, non-antibiotic suppressive therapy for prevention of recurrent urinary tract infections. Same holds true for reflux in children and many other things. And you guys also go through this at times. There are risks and benefits for screening with other cancers like lung cancer, cervical cancer, colon cancer. When you put a patient on statins, you have to talk about the risks of putting somebody on statins and what the benefits are. So and what the patient's preferences, lifestyle preferences are in terms of taking a statin. I know that I personally have a normal cholesterol, low LDH, and my doctor wanted to put me on a statin. I said, why? And he said, well, you're at risk for having heart disease or a stroke. And I said, well, what's my risk? And so we had a shared decision-making conversation where for 3 years, I decided that it wasn't really worth it for me to go on statins. And then we did a CT of my coronary arteries, and my score was 40, which is intermediate risk. And I finally caved and started taking a statin. But same thing holds true with antihypertensive medication treatments of other medical problems that you guys see all the time: migraines, reflux, irritable bowel syndrome, arthritis, et cetera, et cetera, et cetera. So let's talk about shared decision-making in PSA. when we talk about screening, we want to think about it's really not screening because screening implies screening an entire population. So what population do we want to screen? Well, we want to screen men. And what age do we want to screen them at? Well, the U.S. Preventive Task Force recommends maybe having a discussion of men between the ages of 55 and 65 or 70, and to stop testing after age 70 because they say that there's no benefit. I'm going to try and convince you that that's absolutely the wrong age bracket for when to have a shared decision-making conversation. So we already talked about the U.S. Preventive Task Force recommendations, 55 to 69. They're asking you guys to discuss the benefits and harms of prostate cancer screening with your healthcare provider, that would be you, and make an individualized decision about whether or not to get screened. The U.S. Preventive Task Force does not recommend screening for prostate cancer in men, including men with a family history of prostate cancer and men older than the age of 70. I think that's wrong, and I'm going to hopefully show you why that's wrong. The AUA guideline that came out in June of this past year recommends that also clinicians should engage, and they don't say which clinicians. They don't say primary care clinicians. They don't say urologists. They don't say nurse practitioners, PAs. They don't say which clinicians, but clinicians should engage in a shared decision-making conversation with people for whom prostate cancer screening would be appropriate. They don't define that and proceed based on a person's values and preferences. So they recommend using PSA as the first screening test, and that's based by grade A level evidence. And for people that have an elevated PSA, they recommend repeating the PSA, and I would also agree with that. I think before you think about referring a patient to a urologist or consulting one of us MAVEN urologists, just repeat the PSA. Make sure that the patient isn't infected. Make sure that the patient hasn't been traumatized in some way with, say, he fell off a bike and hit his perineum on the bar, and make sure that he hasn't had sex or ejaculation prior to 2 or 3 days prior to obtaining the PSA, because although this is sort of controversial in the literature, I think there's enough evidence to say that ejaculation prior to measuring PSA will cause a false elevation in PSA. There are other things that we'll talk about in a minute about what causes elevations in PSA aside from infections, trauma, and ejaculation. And that the AUA is recommending beginning screening at age 45 to 50 years with level B evidence. I'm going to say that you'll see at as this talk goes on that it makes no sense to start at age 45 when you can start at age 40, because the data is the same in terms of predicting which patients are going to benefit from screening. So, but the AUA recommends starting at age 40 in African Americans, patients who've had germline mutations. That means if the father or brother has had prostate cancer, and their PSA at age 40 is over 1.5, we're going to want to test them for germline mutations. And so patients with a strong family history of prostate cancer. Now, when I talk about germline mutations, you're going to see as this talk goes on that even men that have mothers who've had breast cancer are at higher risk. Beginning at age 40, we're going to talk about a strategy for testing men, but the AUA is recommending regular prostate cancer testing with PSA every 2 to 4 years in people aged 50 to 69 years of age. And we can talk about this a little bit more. And when do you test a man over 70 with PSA? And I would recommend continuing testing testing a man over the age of 70, number one, if they've never had a PSA. Number two, if they've had a family history of PSA, of prostate cancer. That's father or brother. And 3, if their life expectancy is more than 15 years. So if they're totally healthy, if a totally healthy 73-year-old walks into your office on no medication or on a statin, let's say, um, and he's otherwise asymptomatic, get a PSA on him. I'll explain that it's probably beneficial to do that. And they're recommending the rescreening interval, and this is something that's variable, and every 2 to 4 years is probably reasonable, so long as the PSA is associated with low risk. And the whole rectal exam issue can be discussed ad nauseum, but I'm in favor of doing a rectal exam because I think you're going to detect a certain percentage of patients with low risk PSAs, but have very abnormal rectal exams. And I think you're also going to pick up some other rectal pathology that you may not otherwise have known about. PSA velocity is not a good test, so the change in the PSA is not something that the AUA is recommending. There are other ways of enhancing the specificity and sensitivity of PSA, which we'll talk about in a minute. And they're recommending using a validated risk calculator, and I'm going to talk about this at length in a minute. If the clinically significant risk of prostate cancer is low based on data, laboratory imaging, these are people that have been referred to a urologist. You can eliminate the biopsy, and I'm going to talk about that at length. So when you're faced with the question of, should I get a PSA, either when you're asking that of yourself, when a 50-year-old is sitting across the exam table, the exam room from you, or if the patient comes in and asks you, should I get a PSA? You ask yourself, is it worth it for me to do it? I don't have time to be having this discussion. Should I be the one having this discussion, or should the urologist be the one having the discussion? Should I not do it because the U.S. Preventive Task Force doesn't recommend screening? Should I do it only if the patient wants a PSA? If a patient comes in and says, I want you to do a PSA, should I then have the shared decision-making conversation? Or should I just do it anyway and see what happens, and then have the shared decision-making conversation after I get the PSA back? And even though my lab is reporting that PSA greater than 4 is abnormal and PSA less than 4 is normal, I don't know what normal is because Dr. Lieberman told me there is no such thing. So a shared decision-making conversation is recommended in men over the age of 45 by the AUA and by me. I'm going to say that it's better to start at age 40, and I'll explain why in a minute. I'll do a shared decision-making conversation only if they ask me to, or only if they ask me for a PSA. I'll only do it if there's a family history, or if their race, if they're Black, puts them at high risk. I'll just do the PSA on everyone, and do the shared decision-making if the PSA is greater than 4, which is what I thought was normal and what the lab says is normal. I'll just do it, or and then have a shared decision-making conversation with the patient based on their individual risk of having clinically invasive prostate cancer. This implies that the shared decision-making deals with risk and negative. If the risk is negative, then I won't refer to urology for a potential biopsy. So again, U.S. Preventive Task Force does not recommend prostate cancer screening because too many cancers are slow growing and are diagnosed by urologists, and they're taking prostates out unnecessarily. And many people die from these slow growing cancers than from these cancers. They die with the cancer, not from the cancer. And the U.S. Preventive Task Force says you have to screen 1,000 men to save one life. I'll order a PSA, but you need to understand, Mr. So-and-so, that it can be positive and you may not have cancer, or it can be negative and you may have cancer. So it's really not a really good test. So let's just forego it. And you might tell them that the treatment of prostate cancer, the surgery or radiation, is worse than the disease itself. Even if you get prostate cancer, we can treat it with medication like Lupron or something. Even if it's spread, we can treat it and you're not going to die from it. And there's a lot of truth in that. And that's maybe one of the reasons why these screening studies, where they compare control groups to uncontrolled groups, show no difference in mortality, because the treatment of metastatic prostate cancer can go on for years and the patients will die of something else beside prostate cancer. So the surgery may not, or the treatment may not even do you any good, you might say. So rectal exams, again, the guideline says it's optional. Grade C evidence. The U.S. Preventive Task Force said they don't recommend a rectal exam because the evidence suggests it's not beneficial. But the AUA guideline, based on the PROBASE study from Germany, where less than 1% of the population is Black, was what they based their grade C evidence on. So they're really not including population at high risk. And they're going to have abnormal rectal exams. 10% of them will have abnormal rectal exams. 13% of the population in U.S. cities is Black, and metropolitan areas is 30%. So there's a big difference in the data that was used by the AUA in the level C evidence-based recommendation, whether or not to do a rectal exam versus what they really should be using. So a study in, I can't remember what date when this was published, but looked at 526 patients, 76% were Black, 37% had abnormal rectal exams. A rectal exam costs 5 cents for the glove. A tube of KY jelly costs $5. You can do 100 exams. That's also 5 cents per exam. Takes 30 seconds of your time, and your time is $1.60 a minute, or 30 seconds is $1.60. So we've talked about a lot of this. What defines rational, effective, and optimal prostate cancer screening? Who should be screened, how often, and when? When should we not screen? Shared decision-making, who does it? We talked about that. And we're going to talk about future developments, which are currently pretty exciting, actually. Should you screen if you should screen if you can show a reduction in mortality to avoid premature death from the cancer. Can you reduce morbidity? Well, yeah, early diagnosis avoids morbid complications associated with advanced metastatic disease, which is significant. It's interesting that if you read the U.S. Preventive Task Force recommendation, either the 2012 version, level D, or the level C 2018 version, there is no mention whatsoever about morbidity from metastatic disease. I'll say it again, no mention. And that's what this is about. That's what this talk is about. It's preventing morbidity. We're also going to improve mortality, but it's really about preventing morbidity. Is the screening method practical and cost-effective? Are the tests and procedures that are involved in screening non-invasive and are minimally morbid? And what is the sensitivity and specificity of the screening tests? Because if the screening tests are too sensitive, tumors will be diagnosed that are either too small, that is, they don't need to be treated, or too slow growing, that is, the patient will never suffer morbidity or mortality from cancer. And that's one of the criticisms about PSA. It's too sensitive. We're diagnosing, the criticism is that tumors are diagnosed that don't need to be diagnosed. If it's not sensitive enough, then it's a worthless exercise, so there's no reason to do it. A negative test may lead to a false sense of security, and that happens sometimes. About 5% of patients will have PSAs in the low risk range. But those patients will have abnormal rectal exams, and they may even have very aggressive, fast-growing prostate cancer. If the test is low in specificity, that means a lot of false positives. It could potentially lead to more invasive tests that have complications, such as a prostate biopsy or even a treatment. We're not going to treat a false positive, but a false positive can lead to a unnecessary biopsy. Low specificity can produce unnecessary anxiety, which means if the test comes back and is associated with low risk, I'm sorry, if a test comes back and is positive, that is, say somebody comes in with a PSA of 6 and it's a false, so-called false positive, that patient may still be anxious even though the biopsy is negative. So we already talked about a lot of this. If a prostate cancer is confined to the prostate at the time of diagnosis, the 5-year survival is 98%. That's overall no evidence of disease and patients with disease. 10-year survival is 96, 15-year survival is 94%. Goes down a little bit with radiation therapy. However, the advanced and metastatic 5-year disease-free survival is 30%. Quite different. Another important caveat is men that have localized prostate cancer are usually asymptomatic. Advanced and metastatic disease, stage 3 and 4, are incurable, but very treatable with anti-androgens and hormone ablation. There's significant morbidity and expense, which I've already talked about, for treatment of stage 3 and 4 disease. There's significant morbidity for metastatic disease, like pathologic bone fractures, spinal cord compression, thromboembolic, thromboembolic events occur from treatment with anti-androgens and hormone ablation. So localized cancer of the prostate, no symptoms. You don't have symptoms from prostate cancer until you have advanced disease or symptoms from metastatic disease. You can have symptoms from benign enlargement of the prostate, or BPH, and have prostate cancer simultaneously, but those symptoms are not from the cancer, they're from the enlargement of the prostate. So an interesting study was done in Detroit, and what they did was they looked at a population of 30-year-old men who had died of other causes. I recall that all of them were Black. And they took these 30-year-olds and they did autopsies on them. They looked at their prostates and they found that in 30-year-olds, 30% of them had prostate cancer in their prostate. And with that, we learned over the course of years that as each decade progresses, there's a 10% increase in the incidence of prostate cancer. Now, not all these prostate cancers are going to be diagnosed, and a lot of them are never going to be symptomatic because they're indolent. So in a population of 40-year-olds, if you were to do autopsies on every 40-year-old man that died of other causes, there'd be a 40% incidence of prostate cancer. Same for 50-year-olds, 50% incidence, same for 60-year-olds. So my generation of 70-year-olds, we have a 70% risk of having prostate cancer in our prostates. Now, certainly not all of us are going to have clinically significant prostate cancer, and I would submit to you that maybe 10% of us, if we've never had a PSA, fewer than 10%, are going to have clinically significant prostate cancer or high-risk PSAs. So before we had PSA, 50% of men diagnosed with prostate cancer had advanced or metastatic prostate cancer. That means that when I was a resident, I was taking care of, we had a ward full of patients at the VA hospital in Portland, and half of them had metastatic prostate cancer, were getting IV stilfosterol, which is an estrogen, IV estrogen for their metastatic prostate cancer. So we weren't diagnosing men with localized disease. We were diagnosing men with advanced disease. After PSA came around, the stage distribution went from 50% to less than 10% of men presenting with advanced metastatic prostate cancer. I think that's significant. So what's PSA? It's a protein, was discovered in 1979 and found to be associated with prostate cancer. Started being used as a screening test in 1987. We were actually using it in 1985. In 1997, one of the residents and I were sitting around in the office, and my resident came in and said, I just had another one of these guys come in off the street with a PSA of 200, over 200, and obvious bone mets because he's in a lot of pain. And so I said, why don't we look at 100 patients who have presented like this with advanced metastatic disease? I mean, they just come in off the street with advanced prostate cancer, and I want to know how many of them are, do we have 100? And so he went back through the registry and he found 100. And I said, okay, you got 100. Why don't you see how many of them were Kaiser members? Well, 85 of the 100 were Kaiser members. I said, okay, how many of them have been Kaiser members within 10 years prior to being diagnosed with metastatic advanced prostate cancer? Turns out that 85 of them were members for 10 years prior. And I said, well, how many of them had PSAs or rectal exams? Not a single one. Not one patient, having been seen by their primary care physicians 10 years prior to presenting with metastatic disease, had a PSA, had a rectal exam, or even a conversation, a shared decision-making conversation about whether or not to do a PSA. At least it wasn't diagnosed, it wasn't documented in the chart. So the benefit of early detection of prostate cancer is not controversial. And again, there's no such thing as a normally abnormal PSA. Before a shared decision-making conversation can occur, you need to know the risk of whether or not a person has high-grade aggressive cancer. Not all patients with a PSA indicative of high-risk clinically significant prostate cancer are going to get biopsied. And that is even true more now today than it was when I made this slide 2 years ago. So every man has a unique PSA. It's like a fingerprint. PSA can be elevated because the guy has benign enlargement of the prostate. It can be elevated if he has prostatitis or a UTI. It can be elevated if he's been instrumented or recent ejaculation. It varies with age. So a PSA in a 50-year-old, and I'll show you this in a minute, a PSA in a 50-year-old of 2 is not normal, whereas a PSA is associated with low risk of having clinically significant prostate cancer, whereas a PSA of 2 in me is associated with much less risk. And so I'm not going to have a biopsy for my PSA of 2. Even if my PSA was 6, I wouldn't have a biopsy, and I'll tell you about that in a minute. The size of the prostate is important, and we have this is as measured by ultrasound. I know that a lot of urologists think that they can measure the size of the prostate by a rectal exam, which is true because we've done TURPs most of our career, and when you do a TURP, you have your finger in the rectum while you're doing the TURP or before you're doing the TURP. You have a basic idea of how much prostate tissue you're going to resect because you weigh it. So when I put my finger in the rectum, oh, that feels like a 40-gram prostate. Then I do a TURP on the guy, and sure enough, 40 grams resected. So the PSA density is the PSA divided by the PSA volume. So if the PSA is, let's say, 3.5 and the volume is 70, that PSA density is going to be less than 0.08, which is associated with a low risk of clinically significant prostate cancer. PSA velocity is the change of PSA over time. It's important when you're measuring PSA after somebody's been treated. Say you do a radical prostatectomy on a patient. PSA prior to the radical prostatectomy was 8, goes down to 0 after the prostate comes out. And then you start monitoring the patient for recurrence, and the PSA is detectable at 1.0, and then 6 months later, his PSA is 2.0. That PSA velocity is significant because his PSA doubling time is increased in a 6-month period, and that's indicative of high-grade aggressive prostate cancer. Family history is important. Drugs alter prostate cancer. A common drug that makes the PSA go down is a drug called finasteride, which is Proscar. Proscar inhibits the conversion of dihydrotestosterone to testosterone to dihydrotestosterone. It blocks that conversion. So you affect a lowering of the dihydrotestosterone, and that causes the PSA to go down by about 50%. So I'm going to talk about a prostate cancer risk calculator, which is something I think you and your patients can use easily. This one comes from the Cleveland Clinic. It's one that I favor because it's very simple. And what you do is you put these variables in over here. I don't have a pointer, but you can see on the right-hand side of the slide that you put whether or not the patient has ever had a biopsy, how old the patient is, the ethnicity of the patient, family history, yes or no. For prostate cancer, that's brother or father, results of the rectal exam, and what the PSA is. And if the patient has had a percent-free PSA, we'll talk about that in a minute too, you can calculate a risk. So I put some numbers in here for a 66-year-old. If the PSA is 2 in a 66-year-old and the percent-free PSA, you'll get back probability of overall risk of having any cancer is 19.6%. Now that's different than the risk of doing autopsy studies of patients' prostates, because I told you that a 66-year-old has a 60% risk of prostate cancer. So the risk of detecting any prostate cancer on a biopsy in that man would be 20%. The risk of having high-grade prostate cancer in that person, that is a Gleason sum score, and that's a way of looking at the prostate cancer histology. It's graded 1 to 10, and then it's graded on a grading scale of 1 to 10. So we rarely see anything less than 5 or less. 6 would be lower intermediate risk. 7 is intermediate risk. Greater than 7 is high risk, and it goes to 10. So the risk of that would be 6.7%. And as you see, as the PSA goes up with this risk calculator and the percent-free PSA goes down, that the overall risk goes up 40% and 17% for the middle one. And if the PSA is 6 and the free PSA is 10, the risk goes even higher. So the sensitivity PSA is not perfect. At best, it's 75%. The overall positive biopsy rate is variable based on personal experience. And this is pretty much outdated as of 2 years ago. But my personal experience was that when I biopsied a patient for prostate cancer, my biopsy positive rate was about 33%. About a third of the patients had positive biopsies. If there's a high suspicion that the person might have prostate cancer based on risk factors, there's a reason to repeat the biopsy. This has changed too, and I'll explain that in a minute. A repeat biopsy yielded about 20% positivity rate. The risks from a biopsy varied at the time. My personal risk was about 1 or 2%, and that would be bleeding and infection. I think over my 31-year career, I think I hospitalized 1 or 2 patients with a severe infection. And I don't think I ever had to hospitalize a patient from bleeding. There's ways of bleeding can come in the urine or rectally, and there's ways of stopping the bleeding using just some pressure after the biopsy or putting a simple suture in a bleeding vein transrectally. Bleeding in the urine usually stops. In fact, it most always stops, but it's a complication and patients worry about it. And then there's pain from the biopsy. But I'm going to tell you that with our use of ultrasound to do the biopsies, we're able to figure out where the nerves that go alongside the prostate that are responsible for pain in the prostate and also responsible for erection. Those nerves, you can see where they are on ultrasound, and you can easily inject some lidocaine around those nerves and make the biopsy virtually painless. So we've already talked about this. no mention of morbidity in the U.S. Preventive Task Force recommendation. In 2012, I was in the room at the AUA in Atlanta when the U.S. Preventive Task Force authors presented their level D recommendation. And the three studies that are used in the U.S. Preventive Task Force are the PLOC study from the United States, which is prostate, lung, ovary, and colon. The European study, which is prostate only, and the Gothenburg, Sweden study. Those were the studies that were used. The authors of each one of those studies were on the panel when the U.S. Preventive Task Force presented the recommendations. Every one of those authors got up and said, we don't agree with this recommendation. They've misinterpreted our data. The studies are all flawed. They admitted that they were flawed. And they were flawed. First of all, the U.S. Preventive Task Force did not discuss morbidity. They did not discuss both the dollar expense and the patient health expense of morbidity. They did not discuss the stage shift that occurred after PSA was introduced from 50% to 10%. They did not discuss the stage shift in their 2018 recommendation from 10% to over 20%. And there's significant litigation present because of delay in diagnosis of cancer of the prostate in people being sued. The defendants were primary care people who did not do a PSA on their patient, and their patient ultimately presented with metastatic prostate cancer. If you Google litigation for delay in diagnosis of prostate cancer, I did this, there was 130,000 hits on Google. I found one paper that was kind of interesting. It was from Pennsylvania, talked about 106 cases in 1 year, 70 went to trial, 46 were found in favor of the plaintiffs, and most of the defendants were awarded between $1 and $2 million. So I said that I would recommend screening in 40-year-olds, starting screening in 40-year-olds rather than 45-year-olds, because all 40-year-olds, those with positive family history, Black individuals, Black men. So 40-year-olds who we know this is data. These are facts. 40-year-olds who have a PSA greater than 1.5, which all labs will report as normal, or you might have thought of as normal and not to worry about, have a 50% risk of having, greater than 50% risk of having high-grade prostate cancer later in their life. This is the population that you want to screen. This is the population that should be referred to a urologist. Actually, I'm going to tell you in a minute that this is not what they do in Europe. 40-year-olds with a PSA of between 0.5 and 1.5 should have a repeat PSA at 45 or 5 years later. And again, at 50, if their PSA at 45 is still less than 1.5. If it goes above 1.5, at that point, I'm going to say that they should probably be referred to urologists, and the urologist is not going to do a biopsy. The urologist is going to do an MRI. So a 40-year-old with less than 0.5, you can probably wait 10 years and do it again when they're 50. Now, the standard of care is a multiparametric MRI before the prostate biopsy, plus the addition of other much more specific enhancing tests. And I'm going to talk about those in a minute. And those include percent-free PSA, ISO-PSA, ExoDX, PCA3, Stockholm 3, and K4. Now, if you get a PSA on a 50-year-old, let's say it's 1.5, what are you going to do? Well, you're going to ask the guy to come back in a couple of weeks, ask him not to have sex 2 or 3 days before the blood draw, and do a PSA, another PSA, repeat PSA. And at that time, you're going to ask the lab to do a percent-free PSA. It just makes sense to do it that way. So the new blood and urine tests include a PCA3, which is a urine test, free and total PSA, which is percent-free PSA. There's a test that I was involved in, actually. It comes from the Cleveland Clinic. It's called ISO-PSA. It's a blood test. And it's just a way of enhancing the specificity of PSA, or dividing those patients with elevated PSA into those who are high risk or clinically significant versus low risk or clinically insignificant. A new urine test just came out last year called ExoDx. It's a urine test that can be done at home, and it's something that is ordered by urologists. The test is sent to the patient's home. They pee in a cup, they send the test back. And if it's less than 15, it's associated with low risk. Greater than 15, much higher risk. Stockholm 3 is a series of, it's a blood test that's done in Europe and in the United States. And it's I'll talk about that in a minute. The 4K score is a test that measures kallikrein proteins that's also associated when the score is low risk, when it's high risk. And then there's a way of measuring circulating prostate cancer cells. But the MRI is really the new standard of care in patients with high-risk PSAs. There's a test called Oncocyte DX, which is a genomic test, and they're in patients that have family history or of prostate cancer or mothers with breast cancer. A lot of people are recommending BRCA testing analysis because it's elevated in patients who have a high genetic component to their prostate cancer. And there's another genetic test called ATM, which is also associated with high risk inherited prostate cancer. There's ways of deep learning or AI that's using digital scanners looking at microscopic prostate sections. All of this is designed to eliminate the need for unnecessary biopsies and unnecessary treatment. So the new standard of care is multiparametric MRI prior to biopsy because it enhances the specificity of the PSA test and PSA, percent-free PSA. So the way the MRI is looked at is, first of all, the MRI will identify clinically significant cancers likely to progress and will not identify low-grade cancers that are likely to cause no harm in the next 15 to 20 years. And that's based on a score that's given to the MRI findings. And the scores are graded from 1 to 5. It's called a PI-RAD score, P-I-RAD. And when you do the MRI prior to biopsy and find something like a PI-RAD 3, 4, or 5, which means that there's an abnormality in the prostate, you really increase the accuracy of detecting clinically significant prostate cancer and reduce the you reduce the overdiagnosis of indolent disease by 50%. So this is really a sea change in the way that prostate cancer is diagnosed and prostate cancer is early detected. So this study shows that a third to half of men were able to avoid immediate prostate biopsy. So in the United Kingdom and several other European guidelines, MRI has been formally adapted before doing a prostate biopsy. If the MRI is negative, can a trust biopsy be avoided? I would say yes. There's a study called the PROMISE study, which compared the standard trust biopsy to MRI-guided biopsies in men that have not had a prior biopsy. Clinically significant cancer was diagnosed more often in patients with Gleason 4 clinically significant prostate cancer was diagnosed more often, which I've already said. How are we doing for time? I need to speed up. Okay, let me just blow through this. So MRI is more sensitive. There's ways of improving the sensitivity and specificity of prostate cancer screening. It's the new guideline for prostate cancer screening in England. and in other European studies, particularly Sweden. This is actually, the answer to this question is we do. We do an MRI on patients with high-risk PSA now. This is a personal study that I'm aware of because my daughter-in-law's father is a surgeon in Sweden. He's retired and he's currently involved in medical policy making in Sweden. So he's aware of this study this policy at a large hospital in Stockholm, where they offer early detection of prostate cancer in men over the age of 45. They do a Stockholm 3, which I've talked about. It's protein markers and a lot of genetic markers. If the PSA is greater than 1.5, the primary care doctor orders the MRI. If the MRI is negative, they are not referred to urologist. That means the PI-RADS score of the MRI is 1 or 2. They do a follow-up PSA every 2 years. If the PSA is greater than 1.5 and the MRI is abnormal, then they're referred to urology for a targeted perineal biopsy or systematic biopsy, more accurate and less complicated. We've talked about genetic markers, that we've talked about circulating tumor cells. So this has evolved, and it's I would say that it's evolved to the extent that things are really different now. And I would hope that this talk is helping you become aware of the difference in how we all together approach early detection of prostate cancer. And this is my last slide, I think. And this is PSMA stands for prostate specific membrane antigen. It's a PET scan, and it's primarily used for detection of metastatic disease in patients who have been treated who have elevation in their PSA, and you're looking for where are the metastases. These patients that have elevated PSAs after treatment, whether it's surgery, radiation, HIFU, whatever, they're getting PSMA PET scans, and the PSMA PET is more sensitive than the usual bone scan, CT scan, and MRIs that are used to diagnose where the metastatic disease is. But it's also being used before treatment in patients with diagnosed prostate cancer because it's more sensitive and more specific than our tried and true ways of doing the staging workup. That means MRI, CT, and bone scan. It's becoming the standard of care in evaluating biochemical recurrence. That is, a patient that's been treated who has an elevated PSA or rising PSA. And it's currently being investigated to see whether or not it has a role in early detection and screening. And right now, the data shows that it's equivalent to MRI, but probably more sensitive and more specific in diagnosing Gleason 4 and 5 pathology, which means high risk, very clinically significant. So 1 second about shared decision-making in patients who have been diagnosed with prostate cancer. This is something that I wrote in 2014. It's a shared decision-making manual for patients who've been diagnosed with prostate cancer. I worked with Kaiser. I worked at Kaiser for 31 years, and then after I retired, I wrote this. And Kaiser wanted to work with me in producing this booklet, which was produced as a hard copy. And I also wrote a script for a DVD, which is a 20-minute DVD, explaining the options for patients who are diagnosed with prostate cancer. And this is the table of contents of both the DVD and the booklet. And you can see, go through the anatomy, the histology, the staging, grading, and then we talk about risk assessment. What's your risk of having metastatic disease? What's your benefit of having treatment? And we go through all the treatment options, including active surveillance, which is no treatment, because you don't want to treat somebody that's not going to have it's going to have a clinically insignificant cancer. And I would say that a third of the patients nowadays who are diagnosed with prostate cancer choose active surveillance. We know that a third of those patients who are on active surveillance are going to progress. So they're actively monitored. And when they progress, they're treated. And we've shown that there's no difference in waiting to treat them before they progress versus treat them after they've progressed. There's no difference in morbidity or mortality outcomes. So I did this podcast a couple months ago. If you're interested, it was done for primary care doctors, and it's basically a lot of the things that we've talked about during this past hour. But if you're interested, it's 15 minutes. I kind of enjoy doing it. And then from the time that I retired to the time of the pandemic, so for 5 years, I worked for MAVEN and I played a lot of golf. And I got a lot of questions about a lot of different things in urology. And I started writing chapters about some of the things I was questioned about, both by MAVEN. Are we running out of time?
Yeah, we're over time, Dr. Lieberman.
Okay, I'm sorry. Anyway, these are shared decision-making books about everything that happens in your office and in urology. And if you want a copy of one of these books, I'm happy to provide it for you. Just send me. You can check the website out and order the books yourself on Amazon, or I'll send you a couple of copies free of charge if you're interested. And there's a addendum to one of the chapters in the man's book called Should I Get a PSA, which is called PSA for Primary Care Doctors. I'm done. Sorry that I went over.
It's okay, Dr. Lieberman. There are a few questions in the Q&A, so I would recommend everyone that Dr. Lieberman does accept e-consults in our community portal, so please feel free to submit your questions there. And thank you so much for your time today.
We're not going to answer the questions. They're just going to submit them by the portal.
Well, do you have time? We're 3 minutes over.
I have lots of time. I have nothing but time.
I only
I'm
have a few more
retired.
minutes. I only have a few more minutes, but we can get into some of them.
I'm happy to answer questions.
So, okay, I have until 11:15.
Okay.
So, the first question is, in what stage of prostate cancer would it cause enlargement enough to cause obstructive symptoms when it may cause hematuria or hematospermia?
Stage 3 or stage 4?
Okay, thank you. Would you assess for velocity in all patients for which it is decided to get a PSA? And if so, when do you recheck?
Well, it depends on what the baseline PSA is. If the PSA in a 40-year-old is less than 1.5, I'm going to check it again in 2 years. If the PSA in a 50-year-old is 2, I'm going to check it again in 2 years. If the PSA in a 60-year-old is 4, well, first of all, I'm going to do a risk assessment on every patient that I get a PSA on and have a discussion with them about what their risk is. And I'm going to repeat a PSA if it's high risk or significant risk. If a patient is comfortable accepting a risk of 10%, depends on their age. I mean, if my risk were 10%, I'd say, oh, I'm 73 or 2 years old, I'll accept that risk. If I'm 50 and the PSA, the risk is 10%, I'm gonna want to know, because I've got 40 years left to live. I want to know what my risk is. So a lot of that repeat PSA stuff depends on the risk assessment and what the patient is comfortable accepting as a risk. So I hope that answers the question. I think that for a primary care person, do the PSA, do the risk assessment, and then based on the risk assessment, either contact one of us or have a discussion with the patient about how soon you want to repeat the PSA. But the PSA velocity is really a good test for patients who've already been treated for prostate cancer. It's a good predictor of what's happening with that cancer. It's, as the AUA guideline would suggest, it's not the best test. It's not even the top 5 test for assessing risk of having prostate cancer or risk or determining whether or not you're going to get an MRI on that patient or determining whether or not you're going to refer the patient to a urologist. But these are good questions, and all of these questions they're not simple. There's not a simple answer, just as likely as if there's no such thing as a normal PSA. It all has to be put into context of what else is going on.
Okay, thank you. Another question a little bit down below is, if I understand correctly, PSA greater than 1.5 warrants further testing in 40-year-olds. What PSA level warrants further testing in a 60-year-old, a 70-year-old, etc.?
Depends on the risk. You know, do a risk assessment. See what the risk is of having high-grade disease. If the risk of having a high-grade disease is, you know, let's say a 50-year-old, okay? The risk of having high-grade disease with a PSA of 2 in a 50-year-old is going to be significant. It's going to be, you know, more than 20%. So in that case, I would probably have a discussion with the patient. I'd probably call a urologist and ask him if he wants me to do an MRI before I refer him. And I would say that based on a risk assessment, most urologists nowadays are going to say, yeah, go ahead and do the multiparametric MRI of the prostate before you refer him to me. And then if the PI-RAD score on the MRI is 1 or 2, then the urologist, that patient becomes that urologist's patient. And that urologist will follow that patient and determine the interval of PSA testing. That shouldn't be the responsibility of a primary care doctor. I hope that answers the question. Again, it's complicated. It's not simple. It has to be viewed as something within the context of that patient's personal preferences and his tolerance for risk of having prostate cancer. Okay.
Thank you. The next question is, our EMR gives us a choice of total PSA, ultrasensitive screen, or PSA free and total. It sounds like the latter is the test to order for screening, but what is this ultrasensitive screen?
Ultrasensitive screen is after a patient's been treated for prostate cancer and their PSA becomes undetectable. That undetectable means less than 0.05. Okay. An ultrasensitive screen will detect levels below 0.05. So it's only used for patients that have been treated for prostate cancer, who have an undetectable PSA, who want to know whether or not they really are undetectable. There's no place for a primary care doctor to order an ultrasensitive PSA. In fact, I didn't find it very useful at all in practice. So in the practice of following and treating patients with prostate cancer. So as far as the percent-free PSA, I recommend that you do just a total PSA first. And if it's high risk, then you're going to repeat the PSA anyway, you know, unless it's really low risk. Say you do a PSA on a 60-year-old and it comes back 1.5. You're not going to repeat that. You know, you'll probably repeat it maybe in 2 years or 4 years. That's what the AUA guideline would recommend. So a PSA of 1.5 in a 60-year-old, no need to repeat it. PSA even of 2.5 in a 65-year-old, no need to repeat it. The risk of having clinically significant prostate cancer in that person is less than 10. However, If in a 65-year-old, the PSA is 4, which would be regarded as normal, then you should probably repeat a PSA in 3 weeks and do a percent free PSA at the same time because it's easy. You just order free and total PSA. Okay.
Okay, thank
I
you.
hope that answers the question.
The next question we have is, what if we refer a 40-year-old with a PSA over 1.5 and the urologist questions why the referral was made? Do urologists in general think like you do, or do we need to educate them?
That's an unfair question. I would say any urologist that's read the guideline would agree with me. I mean, yeah, any urologist that's passed his boards as a board certified urologist would agree with me. And if they don't, send them to us. I mean, send the referral to us because I'm quite sure that the 4 MAVEN urologists would all agree that a PSA of greater than 1.5 in a 40-year-old, we all know the data, we all know the papers, and that's just the way it is. And a PSA of a greater than 1.5 in a 45-year-old or a 40-year-old is not normal. That person, even if the MRI is negative, that person's not going to be biopsied, but he is going to be followed by a urologist because that PSA of 1.5 and that negative MRI at age 45 may be really abnormal at age 50. And that's when you want to treat him. That's when you want to treat. You don't want to wait until he's 55. You don't want to send him back to the primary care doctor and say, oh, this guy had a normal MRI. He's 45, but even though his PSA is 2, I don't need to see him anymore. A good urologist is not going to do that. Next question.
So the next question is insurance on board with these improved recommendations, or should we expect to need to argue with insurance, for example, to have an MRI covered for a 40-year-old with a PSA greater than 1.5, as you mentioned?
Wow, that's a really good question. I don't know the answer to that. I honestly do not know the answer to that. First of all, I worked at Kaiser, so I never dealt with insurance companies. Second of all, the people that I'm currently working with are Kaiser physicians. Actively practicing Kaiser physicians. I'm still doing some clinical research with some Kaiser guys, and they don't worry about this. So that's a great question. I don't know. I think if it comes up, send me a consult, and I'll be the one that argues with the insurance companies. You don't have to do that. I will.
Thank you, Dr.
I hope that
Lieberman.
answers the question.
Absolutely. And I think everyone will appreciate your support. And then the last question we have, which we'll be able to answer, is the best, or well, this actually is the last question in general, but is the best risk calculator the Cleveland Clinic one?
In my opinion, yes, because it's easy, it's simple, it's free. There are others that I've looked at online. Um, there are more detailed and involved risk calculators, and the risk calculators are changing based on MRI, based on ExoDX, based on Stockholm 3, based on 4K studies. The risk calculators are changing. The Cleveland Clinic has not changed their risk calculator, but it's so simple and it's so easy, and it puts you in that it's something that you can talk to your patient about. It's a hard number. You can tell them your risk of having clinically invasive prostate cancer is 19%. I think you should have an MRI, and I think you should be referred to a urologist after that MRI. And you and the urologist will talk about whether or not a biopsy, you and your urologist will have a shared decision-making conversation about whether or not you should have a biopsy, what the risks and benefits are for you to have that biopsy, and what the likelihood of that biopsy being positive or negative based on your MRI. And I would say that I do stuff outside of MAVEN in around this topic, but I've been asked to comment on patients who've had high-risk PSAs, elevated PSAs, but normal PI-RAD scores, 1 or 2. And I would tell them, I don't think your PSA is elevated from prostate cancer. I think it's elevated because your prostate is 70 grams. And we've done a PSA density, and we got data to show that you're not at risk. You don't need to be anxious about this. You don't need to have a biopsy. And I've had others that have said my PI-RAD score is 3, which is kind of borderline. It's not 4. 4 or 5 is very likely to have cancer and very likely to be positive. And I've had others that say, I think you should have another biopsy, or I think you should have this other test, an ExoDx. And I go through this a lot with other urologists, with people outside of MAVEN, but I think it's complicated and it's changing all the time. And I think you need to be flexible, but at the same time, I think you need to be aware of the fact that not doing a PSA or telling a patient that you don't need a PSA or that I don't believe in a PSA is actually harmful to the system and harmful to your individual patients. Okay.
Thank you so much, Dr. Lieberman, for staying over, and we just got a nice thank you in the chat. And always appreciate you teaching, Dr. Lieberman, is the nice comment. So again, thank you so much for your time today, and I hope everyone has a great afternoon.
Everybody's welcome to the book. Just let me know who wants it. There's I haven't gotten a lot of feedback. I've gotten some feedback from when I get a MAVEN consult and there's something in the book that would be helpful, I write them a note and I say, look, I wrote these 2 books. MAVEN and I are happy to provide you with the books free of charge. Just give me your address, a good mailing address, and a phone number in case Amazon can't deliver the books to you. And I've gotten some feedback that they've been helpful. So they're written for patients, so that patients can understand what they're talking to you about when you have a shared decision-making conversation. Mm-hmm. The books are all about shared decision-making. It's all about improving healthcare literacy. So thanks. Yeah, I appreciate you giving me the time to give this talk, and I'm happy to do it again if there's enough interest.
Yeah, absolutely. I'm sure we'll be working together again soon.
Okay. Thanks, Aaron.
Thank you.